Hello everyone. Many of us are not aware of the findings and interpretation of X-ray chest nowadays because of the feasibility of echo and CT and intervention in this millennium. Few of us, especially the undergraduates before the year 2000, they would not have forgotten the speech of some of the physicians and the radiologists who could talk for hours about assessing the heart on X-ray chest because those findings are detected earlier now due to echo and BHR CT chest. Here I am giving only one X-ray chest with no clinical history. You have to give all the findings in this X-ray chest. Tell me what's the diagnosis. In this X-ray chest, can you say about the treatment the patient had undergone? If you want more time, please pause the video and review the X-ray chest. Within few seconds through this X-ray chest, I will elaborate the findings, its diagnosis and the treatment the patient had undergone. Are you ready? Let's go. We can assess the abnormal findings in the X-ray chest in comparison with the normal X-ray chest. So you will see the abnormal X-ray chest on the left side and a normal X-ray chest on the right side so that the findings will be easily eye-catching to everyone. First point, normal X-ray chest shows normal cardiac contour which is less than or equal to half of the thoracic diameter. In the abnormal X-ray chest, there is significant cardiomegaly even in our visual impression. The second point, normal X-ray chest, there is 1/3 of cardiac contour to right of the bony spine and 2/3 of cardiac contour to left of the bony spine. But in the abnormal X-ray chest, it is almost reversed. I mean, 2/3 of cardiac contour to be seen to right of the bony spine and 1/3 being to left of the bony spine. This indicates significant enlargement of the right atrium or the right ventricle, or it can be both. Third point, normally there is concave or straight space between the aorta and the pulmonary artery, which is well above the left main bronchus. You can see the clear space between the aorta and the pulmonary artery in the normal X-ray. If it becomes convex or appears bulky more than the aortic level, it is abnormal due to so many reasons. With cardiac problems, it can be due to pulmonary venous congestion or due to pulmonary arterial hypertension or due to left atrial enlargement. With all of them will be seen above the left main bronchus. Without any cardiac problems, if there is abnormal convexity or bulge in the aortopulmonary region, it could be due to a lot of other pathologies. Please go through the picture. 3 left-sided nerves are noted in the aortopulmonary level. They are the phrenic nerve, vagus nerve and recurrent laryngeal nerve. Don't forget about the ligamentum arteriosum too, due to closure of the ductus arteriosus after birth, and very importantly, enlarged lymph nodes can also obtuse the aortopulmonary level. Now we will go to the fourth point, the carinal angle, which is always below 90 degrees. Actually, it is usually between 50 to 80 degree. Our normal X-ray chest shows less than 50 degree at the carinal angle. If it is more than 90 degree, it could be due to either cardiac or extracardiac pathologies. In our abnormal X-ray chest with cardiac pathology, there is severe widening of the carinal angle, which is the most sensitive marker of severe left atrial enlargement, and the angle shows 110 to 120 degree widening due to severe enlargement of left atrium, which is lifted up and is narrowing the left main bronchus. Now we'll go to the fifth point, the right cardiac contour. In our case, there is doubling of right heart border due to enlargement of the left atrium. So we talked about the 3 findings of severe left atrial enlargement in our case. One is the bulging at the aortopulmonary level. Second one is widening of the carinal angle. And the third one is double density in the right side of heart. We discussed about the cardiac findings in our case. Now we will discuss about the lung findings in our case. First one is cephalization, which indicates dilatation of the superior pulmonary veins and its tributaries. In the normal X-ray chest, there is no cephalization, but in the abnormal X-ray chest, there is engorged left pulmonary vein with dilatation of the tributaries, which is classical of cephalization. If it is the predominant finding, it is called as Stack's antlers. In our case, it's not very predominant. Second one is curly lines. These curly lines are engorged lymphatics in the lungs called as curly A lines or B lines, C lines and D lines by the distribution and location. Now we'll go to the curly A lines or long perihilar lines due to the lymphatic engorgement along the peribronchovascular sheath on HRCT called as interlobular septal thickening in the peribronchovascular distribution. Now we'll go to the curly B lines, which are short horizontal subpleural lines. On HRCT, they are perpendicular to the pleural surface. The curly C lines in the X-ray chest are the interlobular septal thickening in between the peribronchovascular sheath and the pleural space. On HRCT, it is classically seen along the fissures with septal thickening. And lastly, the curly D lines are the lines seen in the lateral X-ray chest in the retrosternal air-filled lungs. In our normal X-ray chest, no such curly lines are noted, but the abnormal X-ray chest shows all the curly lines, but not typical of curly A lines in the perihilar region, but can detect curly B lines in the subpleural surface above the right CP angle and multiple curly C-like lines are also detected between the right CP angle and the right hilum, but not sure about the curly C lines, but very confident about the presence of curly B lines. In addition, diffuse ill-defined confluent opacities are noted in both the lungs, more on the left, with relative free space between the lung apices and the bilateral CP angles, which are suggestive of pulmonary edema more due to predominant right ventricular failure. Now I have discussed about the findings in the abnormal X-ray chest. The diagnosis is simple and straightforward. The diagnosis is long-standing mitral stenosis and its sequelae. Last question in our quiz was, what's the treatment the patient had undergone? I think nobody would miss the findings because it's highly catching with the presence of sternotomy sutures and the mitral valve prosthetic valve in the X-ray chest. Now we will discuss about the X-ray chest findings in mitral stenosis. In the early stage of mitral stenosis, the X-ray chest would look normal. Depending to the degree of stenosis, there will be increased left atrial pressure with some dilatation of the left atrium, which may not be evident on X-ray chest. After some more time, there will be dilatation of the superior pulmonary veins, which would be called as cephalization on X-ray chest. That could be the only X-ray chest finding in the early stage with normal heart, and this is called as stag's antlers. Here the mitral stenosis will be detected on echo easily. After that, there will be pulmonary interstitial edema, which might be evident by visualization of curly B lines on X-ray chest. Till now, there may not be cardiomegaly or typical evidence of left atrial enlargement except the cephalization of the pulmonary veins. Only after that, the left atrial enlargement becomes very much evident by the presence of obtuse aortopulmonary level. If there is significant prominence of the left atrial appendage below the left main bronchus, it is called as third Mogul sign. Why this is being named as third Mogul? Other Moguls? There are so many Moguls, which means bulges in the normal or abnormal left cardiac contour. The first bulge or the first Mogul is the distal aortic arch. Second bulge is the pulmonary artery, and the third Mogul is the dilated left atrial appendage, which will be seen below the left main bronchus. Fourth one is the left ventricular contour, and the fifth one is the prominent left cardiac fat pad. In our case, no Moguls are detected due to severity and due to the straightening of the left cardiac contour. In mitral stenosis, left atrial enlargement is indicated by cephalization called as stag's antlers, already mentioned. Then cranial widening, more than 90-degree angle, and double density sign or double right atrium. If the left atrial enlargement is very severe, more dilated than the right atrium, then it is seen around the right atrium, which is called as atrial escape, and the dilated left atrium might be called as football left atrium. With so much of progression, there is increased vascular resistance which hampers the right ventricular function, which is dilating it with right ventricular hypertrophy. After many years, there is possibility of moderate to severe cardiomegaly with findings of severe right ventricular failure if not managed conservatively or surgically. Okay, that's end of the session. Please give your opinion and suggestion in the comment section. If you're interested in the other quizzes already uploaded, you can click the blue colored R button to see rest of the quiz list. You can click and go through the quizzes if you're interested. Thank you very much for your patient hearing. We will meet again with another quiz. All the best. Take care.